Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. Welcome to part 25 of our Pharmacotherapy MCQ series. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty at your workplace. So I would like to urge you to sit back and spare me part of your very precious time as I share some tips that you may find useful in your line of duty. So welcome back. So in question 1, Mrs. WKT is a 75-year-old white female patient who presents to the cardiology clinic at your hospital. Her current medications include lisinopril taken at a dose of 40 milligrams once daily, chlorthalidone, a diuretic taken at a dose of 25 milligrams orally once a day, and the calcium channel blocker carvedilol taken at a dose of 25 milligrams twice daily orally. Her first set of blood pressure readings are 153 systolic, 93 diastolic, with a heart rate of 58. Now you give us some time to rest and settle and calm down and repeat the readings, which are 149 systolic and 89 diastolic, and the heart rate rises slightly to a level of 60. All her labs are within normal units, and your cardiac team decides to prescribe an additional antihypertensive medication, but they are concerned about lowering this lady's heart rate further because of her age and the risks involved. Which of the drugs listed below would be a poor or a wrong choice due to its likelihood of lowering WKT's heart rate, which is already on the lower side of normal? Is it hydralazine, amlodipine, terazosin, or verapamil? I'll give you 10 seconds to choose the correct answer. So verapamil it is. Now, Madam WKT has resistant hypertension, and the reason why is because of her poor BP control, despite being on 3 drugs from 3 different classes, one of which is a diuretic, chlorthalidone. She needs further BP lowering, but without lowering her heart rate, since she already has borderline bradycardia, and she is at risk of orthostasis. Verapamil, which is a non-dihydropyridine calcium channel blocker, sorry for that slip, has SA and AV nodal blocking activity in the heart, and this can cause a negative chronotropic effect. That is, it can slow down the rate of the heart, and thus would be a poor selection in this patient if we are trying to avoid a further decrease or lowering of the heart rate. Now, amlodipine is also a dihydropyridine calcium channel blocker. It has a far greater vascular selectivity with minimal, if any, effects on the heart rate. It would be superior to verapamil. In fact, it may cause a a rebound increase in heart rate due to its vasodilatory effect. Then both hydralazine, which is a directly acting vasodilator, and the other drug in C, which is terazosin, that is an alpha-1 blocking agent, may cause a rebound increase in heart rate due to their vasodilatory properties. So in this case, the culprit would be verapamil. I would not opt for it. The other three would serve the purpose. Let's move to the next slide. Madam JJK is a 60-year-old black female patient who presents to the cardiac clinic with a past medical history of osteoarthritis, type 2 diabetes mellitus, RJ incontinence, and hypertension. She is currently taking 1,000 milligrams of metformin twice daily after breakfast and dinner, losartan 50 milligrams orally once a day, oxybutynin at a dose of 5 milligrams thrice daily, Atorvastatin on an high-intensity statin therapy at a dose of 40 milligrams at night, and periodically she relieves her pain with 500 milligrams of paracetamol when needed, up to 4 times daily. She reports adherence to all the medications on that list and complains of muscular pain when the dose of atorvastatin was increased to the upper limit of the high-intensity statin therapy, which is 80 milligrams at night. She didn't tolerate it well, and it was done for 60 days. She cannot cope with the upper limit of 80 milligrams. Blood pressure today is 156, systolic 87 diastolic. She has an A1C of 5.8, TG of 119, TC of 194, LDL-C of 123, HDL of 48, AST and ALT and the serum creatinine are within normal limits. So nothing to worry about the kidneys much, the liver much, and her ASVT, atherosclerotic cardiovascular disease risk score, is pretty high, 32.2% based on the current risk factors. My question to you is, what would be your most appropriate recommendation for cholesterol management in the case of JJK? Would you increase the atorvastatin further beyond the 80 or 40 milligram mark? Or would you initiate Ezetimibe? Or would you initiate Fenofibrate? Or would you swap atorvastatin with Simvastatin? I'll give you 10 seconds to choose the correct answer from that list. Personally, I would opt for addition of Ezetimibe to the 40 milligrams of atorvastatin. Now, in patients with very high risk of atherosclerotic cardiovascular disease, it is reasonable to add Ezetimibe to the maximally tolerated statin dose, which is 40 in our case. Fibrate therapy, in my opinion, may be indicated if the TG levels exceed 500 milligrams per deciliter. We are not yet there. Now, this patient did not tolerate a higher atorvastatin dose of 80 in the past, and it would be inappropriate to increase the dose at this time. We would be back to where we were, where she was complaining of the muscle ache. And changing to Simvastatin would require a reduction in the intensity of the statin, which would be inappropriate at this time because of her atherosclerotic cardiovascular disease risk. We need high intensity statin, not low or medium. And patients who are on maximally tolerated statin dose have a high risk of atherosclerotic cardiovascular disease, I'll repeat that. Such patients who have a risk of 20% or more of the atherosclerotic cardiovascular disease of 20% or more, and an LDL cholesterol of 70 or higher may gain up to 20% more LDL cholesterol lowering with the addition of ezetimibe. So literature out there says it adds value when added to a high intensity statin therapy. So I would opt for ezetimibe. So that's just a by the way. Let's move to the next question. Mr. RMC is a 59-year-old Caucasian man who has unstable angina and is being managed conservatively. My question to you is, which of the features below would not merit a diagnostic angiography in this particular patient? Would it be a heart failure? Would it be recurrent symptoms or ischemia? Would it be serious arrhythmias or hypertension? I'll give you 10 seconds to choose the correct answer. So hypertension it is. Recurrent symptoms of or ischemia, heart failure, and serious arrhythmias would necessitate a diagnostic angiography, in my opinion, in any patient initially receiving conservative therapy for either unstable angina or NSTEMI. And that is a class 1 level B recommendation. So the only odd figure out there would be hypertension. Let's move to the next slide. Mr. P.O.B. is a 50-year-old male of African origin who is being evaluated for dyslipidemia management. He has a past medical history of type 2 diabetes mellitus. He is hypertensive, has issues with gout. He is obese and he smokes cigarettes. He abuses or uses cigarettes, currently smoking 1 packet per day. The fasting lipid panel shows the following. The total cholesterol is 268, HDL is 25, LDL from the information provided you are unable to calculate. The TG is 509, it's above the 500 mark, note that. Then the direct LDL is given as 123. So my question to you is, which of the medical conditions listed below could be a secondary cause of his dyslipidemia? Is it hypertension, gout, type 2 diabetes mellitus, or obesity? I'll give you 10 seconds to choose the correct answer. So in my opinion, it's type 2 diabetes. Now, secondary causes of hyperlipidemia include type 2 diabetes mellitus, hypothyroidism, obstructive liver disease, chronic kidney failure can also cause it, then drug therapies at times, and the biggest culprit or the most frequent cause would be type 2 diabetes in this particular gentleman's case from that list. Now, it's common to see TG levels elevated in the setting of a poor overall glycemic control. The initial step should be to determine the patient's overall DM control and improve his glycemic control if need be. That would help manage the hyperlipidemia quite a bit. Now, the repeat of his fasting lipid panel would be in order after you've instituted these changes, after you've endeavored to control his sugars, to determine if there are any improvements in the hyperlipidemia before you embark on medication. Now, because this gentleman is diabetic, it would be reasonable to consider starting lipid-lowering therapy. While managing his type 2 diabetes mellitus, since his LDL is likely elevated. Now, use of a statin with more potent triglyceride lowering capability, such as Atorvastatin or Rosuvastatin, would also assist in lowering the TG to minimize the risks of pancreatitis. Just by the way. So let's move to the next question, which reads, which of the mechanisms of action below best corresponds to our diuretic metolazone, otherwise known as Zaroxolene? Does it inhibit water and sodium reabsorption in the proximal convoluted tubule of the nephron, or does it inhibit sodium and water reabsorption by blocking the effect of aldosterone in the distal convoluted tubule, or does it inhibit the activity of antidiuretic hormone at the V2 receptor in the collecting duct, or does it inhibit water and sodium reabsorption in the distal convoluted tubule by inhibiting the sodium chloride co-transporter? I'll give you 10 seconds to choose from the 4 options. So I would settle for answer D. It actually inhibits water and sodium reabsorption in the distal convoluted tubule by inhibiting the sodium chloride co-transporter. It is known to be a weak acid which requires active secretion into the proximal convoluted tubule via organic acid pathway. Now, once in this renal tubule, metolazone is delivered to the distal renal tubule, where it may inhibit the reabsorption of sodium and water by blocking the sodium chloride co-transporter on the luminous side of the tubule. So answer B is the mechanism of action that applies to the aldosterone antagonist, not this particular drug. So that would apply to spironolactone and eplerenone. And then the mechanism described in C applies to the drugs that we use for treating hyponatremia, not for our dear friend which we call metolazone. So I would opt for D as the best answer. Let's move to the next question, which says, which of the antiplatelets listed below commonly causes dyspnea, shortness of breath, from studies? Is it Brilinta, is it Effient, is it Plavix, or is it Varopaxa? I'll give you 10 seconds to choose from that list of 4. So ticagrelor is, according to the Plato and the Pegasus trials, 14% of patients on ticagrelor experienced dyspnea. Now, the other drugs did not have issues at all. So A would be our correct answer in this particular case. It is the major cause of dyspnea in patients who are receiving this set of drugs. Let's move to the next question. Mr. BJO is a 74-year-old white man with a refractory angina, and he experiences, according to him, 2 to 3 episodes daily, despite the use of maximally tolerated traditional anti-anginal therapy. So you decide as a team to administer or to introduce or to initiate ranolazine to this gentleman, but you're concerned of potential adverse drug reactions. He's currently taking aspirin prophylactically at a dose of 81 milligrams orally once a day, isosorbide dinitrate at a dose of 40 milligrams thrice daily, lisinopril at a dose of 40 milligrams once a day, and metoprolol tartrate 100 milligrams orally twice daily, and simvastatin 40 milligrams at bedtime. So my question to you is, which of the drugs listed below has a drug-drug interaction with ranolazine? Is it lisinopril, isosorbide dinitrate, metoprolol tartrate, or simvastatin? I'll give you 10 seconds to choose the correct answer. So simvastatin it is. Now ranolazine is a CYP453A substrate, which may increase the serum concentration of other CYP453A substrates. Now simvastatin doses should be limited to 20 milligrams at night, since this drug we would like to introduce, ranolazine, increases its end area under the curve twofold. Now, other substrates for your information include cyclosporin, tacrolimus, and sirolimus, which are used in transplant. And these drugs have narrow indices, and their doses would also need to be reduced if we administer them concurrently with ranolazine. Now, ranolazine is also a P-glycoprotein substrate and a CYP2D6 substrate as well. So drugs transported by P-glycoprotein or metabolized by 2D6, such as digoxin and the tricyclic antidepressants, may require reduced doses when co-administered with it. Just for your information. Now, moderate CYP3A inhibitors like diltiazem and verapamil and erythromycin and P-glycoprotein inhibitors such as cyclosporin can increase serum concentrations of ranolazine itself. So if they are co-administered, you need to be cautious. Now, with these concurrent agents, ranolazine doses should be limited to 500 milligrams BD. And it can be titrated cautiously based on the patient's clinical response and how well they tolerate the drugs administered concurrently. Now, ranolazine use is contraindicated with the strong CYP4A inhibitors such as ketoconazole, clarithromycin, and the ARV nelfinavir, which we use less and less in therapy. And should also be cautious, it is contraindicated in the strong CYP3A inducers such as rifampicin, phenobarbital, or the herb St. John's wort. So just for your information, if you opt to add it to this patient's regimen, then you need to be cautious about those drugs I've just brushed through. But in this particular case, we would expect a drug-drug interaction with simvastatin. It has no drug-drug interactions recorded in history with lisinopril, with isosorbide dinitrate, or with metoprolol tartrate. So I would leave those as is, but I would tweak the simvastatin dose or opt to substitute it altogether. Let's move to the next question. So our next question reads, which of the stages of heart failure listed below is most commonly associated with the presence of structural heart disease and symptoms that usually merit the administration of loop diuretics or aldosterone antagonist therapy without the need for specialized intervention beyond drug therapy? Is it stage C, B, A, or D? And give you 10 seconds to choose the correct answer. In my opinion, it's stage C. According to the ACC and AHA, they categorize heart failure in 4 stages, which are A, B, C, and D. Now, in stage A, we have the patients that are at a high risk for heart failure but don't have structural heart disease or symptoms of heart failure. Now, stage B, if I remember well, are those patients that have evidence of structural heart disease but no symptoms associated with heart failure itself. And in stage C, the patients have evidence of structural heart disease and symptoms of heart failure. Now, in stage D, we have the patients who usually have structural heart disease and symptoms, and it's also associated with refractory cases that are refractory to treatment and may also require specialized intervention with, for example, an implantable defibrillator to stabilize. So once a patient gets to stage C, which is an equivalent of the NYHA functional classification 3, heart failure, the patients have an evidence of structural heart disease on echo, and they're usually symptomatic to the extent that they require treatment with loop diuretics at stage C, to be precise. And usually at this point, patients already, if you followed guidelines, are already on an S inhibitor or an ARB, a beta blocker, and a diuretic, where the addition of an aldosterone antagonist may then be considered, assuming the patient has no evidence of baseline hyperkalemia or worsening renal function. Those are the only 2 that would make me reluctant to add on an aldosterone antagonist. So stage C would be the correct answer in my opinion. Let's move to the next question, which reads, PWM, who has had intermittent episodes of SVT, has briefly been on amiodarone for his rhythm control. So my question to you is, which of the statements below is accurate about the use of amiodarone in BWM's treatment? Is amiodarone associated with the development of pulmonary fibrosis in some patients? Or is it true that it belongs to class 4 of the antiarrhythmic drugs? Or is it true that it can inhibit both the P-glycoprotein and the CYP3A4? Or is it true that both its oral and parenteral formulations contain iodine? I'll give you 10 seconds to choose the correct answer or answers. So in my opinion, answer B is wrong. The other 3 are correct. So amiodarone belongs to class 3, not class 4 of the antiarrhythmic agents, and its common side effects include pulmonary fibrosis, ocular toxicity, and disturbance. It can cause QT prolongation. It causes liver toxicity, thyroid dysfunction due to the large concentration of iodine in both IV and oral formulations, and this iodine disrupts the function of the thyroid. It disrupts thyroid hormone production and release, and it can also cause dermatologic complications. It also has drug-drug interactions due to its ability to inhibit the CYP3A4 and the P-glycoprotein, which is an efflux pump or a transporter. Now, warfarin and digoxin doses must be reduced when they are co-administered with amiodarone. There are drug-drug interactions there that can have far-reaching consequences. Other examples of class 4 antiarrhythmics, just as by the way, are verapamil and diltiazem. So let's move to the next slide. Which of the calcium channel blockers listed below reduces afterload and has negative dromotropic and ionotropic effects in pacemaker cells of the heart, and thereby has an effect on the pulse rate? Is it verapamil, amlodipine, nifedipine, or bisoprolol? I'll give you 10 seconds to choose the correct answer. So verapamil it is. Verapamil is the only non-dihydropyridine calcium channel blocker listed that can reduce both heart rate through the prolongation of the AV nodal conduction, which is dromotropy. It can reduce the force of contraction and cause peripheral vasodilation, which reduces afterload. Non-dihydropyridine calcium channel blockers usually inhibit phase 0 of the action potential. That leads to a reduction in the pulse because of the delay in conduction, to be specific. This is also the reason why some patients can develop heart block while taking this type of calcium channel blocker. So you have to be very careful when on them. Now, amlodipine and nifedipine, that is B and C, cause peripheral vasodilation and they reduce afterload, and only with a slight increase in heart rate. Now, bisoprolol, alternative D, is not a calcium channel blocker, so it automatically falls off. It's a beta-1 selective beta blocker. So our right answer here would be verapamil, answer A. Let's move to the next question. Which statement below most accurately describes the mechanism of action of metoprolol succinate? Is it true that it has negative chronotropic effects which leads to a reduction in heart rate? Or is it true that it has a positive dromotropic effect and thus decreases heart rate? Or does it antagonize the beta-1 receptor, which can increase cytoplasmic calcium concentration needed for muscular contraction? Or can it decrease cardiac output because of its ability to increase chronotropy? I'll give you 10 seconds to choose the correct answer. Opinion A is the correct answer. Beta blockers have the following mechanism of action on the heart. They can reduce the pulse or the heart rate because of their ability to inhibit phase 4 of the action potential in cardiac pacemaker cells, resulting in negative chronotropic effect. They reduce the cardiac output due to negative ionotropic effect on the heart due to the antagonism of beta-1 receptors in the heart itself, and that inhibits sarcoplasmic reticulum's ability to increase cytoplasmic concentration of calcium. And calcium, as we know, is needed for myosin and actin to interact to cause muscular contraction. Now, the reduction in chronotropy and ionotropy both contribute to the reduction in cardiac output, which contributes to the blood pressure lowering effects. Now, if we remember well, BP is equal to cardiac output times SVR, where cardiac output is heart rate times stroke volume. And stroke volume is influenced by preload, anotropy, and afterload. So I would settle for A after all is said and done. Let's move to the next question. Mrs. UKM is a 46-year-old female who had some form of accident and has a multi-system trauma. She's admitted to a surgical ICU, and this is her 4th day in the ICU. She's mechanically ventilated, sedated, and she's receiving supportive care, including venous thromboembolism prophylaxis with heparin at a dose of 5,000 units administered subcutaneously twice daily. Her APTT is within the normal range. She is now tachycardic, hypotensive, and hypoxic, and has remained in that state despite adjustments to vasopressor, sedation, and the ventilation settings. Now you do a CT chest and identify a PE, and the team intends to administer alteplase. So my question to you is, which of the actions listed below would be the most appropriate to take in UKM's case? Would you administer alteplase at a dose of 100 milligrams IV, broken down into a bolus of 10% of the total dose, and then the balance infused over 2 hours? Or would you administer alteplase at a dose of 0.9 milligrams per kilo IV, with 10% as bolus and the remainder over an hour? Or, in your opinion, is alteplase contraindicated in this patient's case? Or would you shun alteplase and instead administer tenecteplase at a dose of 50 milligrams via IV bolus? I'll give you 10 seconds to choose the correct answer. In my opinion, A is the correct answer. I would like to start off by saying that patients receiving heparin at doses below 10,000 units or equivalent doses of low molecular weight heparins for the preventions of DVT, according to studies, did not experience an increase in the incidences of intracranial hemorrhage when they received alteplase for stroke in a study called the NINDS trial. Now, for acute PE patients who have not had heparin within the past 2 hours prior to a decision to administer alteplase, and may require fibrinolysis, and for the patients receiving prophylactic doses of heparin without prolongation of ATTT, they are considered eligible to receive alteplase. There would be no issues there. Now, the appropriate dose of alteplase for PE is 100 milligrams administered IV, but broken down in such a manner that 10% is administered as a bolus and the remainder is infused continuously over the next 120 minutes. Now, alternative B, which is a dose of 0.9 per kilo, is the dosing regimen for acute ischemic stroke, not for PE, so I wouldn't go there. And then tenecteplase is used primarily for STEMI, so I wouldn't opt for D either. And our patient qualifies for administration of alteplase. I don't see a contraindication basing on the NINDS trial. Now, in patients with high suspicion for PE, rapid initiation of therapeutic anticoagulation is recommended, so that makes C incorrect. Now, although the chest guidelines suggest low molecular weights heparins over the unfractionated heparin, the latter is usually initiated to preserve the use of alteplase. Now, if patients receive therapeutic doses of low molecular weight heparins, they are contraindicated to receive alteplase, where therapeutic heparin may be held for 120 minutes to allow for alteplase administration. So I would be safer or more comfortable in administering alteplase to patients on the unfractionated heparin because of its shorter half-life compared to the low molecular weight heparins that would take a longer time to clear off from the body, and there would be risks of hemorrhage if you have administered alteplase in patients who had already received enoxaparin and the other low molecular weight heparins. Now, so patients who require pharmacologic intervention to control the hypertension in order to be eligible for alteplase must continue to have their BP maintained below 185 systolic, 110 diastolic for at least the duration of the alteplase infusion. And then for that small category of patients on warfarin, at the time of evaluation for alteplase therapy, they may be eligible to receive alteplase if the INR is equal to or less than 1.7 at the time of the workup. So don't deny the warfarin patients in a blanket manner the option of receiving alteplase if they have PE. That's just a by the way. So let's move to the next question. You are managing a dyslipidemic patient with a past medical history of carotid artery disease, hypertension, and obesity. He was initiated on Atorvastatin 40 milligrams at night 42 days ago, and there have been 2 sets of fasting lipid panel tests. 42 days ago, his total cholesterol was 220, today it's 172, HDL was 32, today it's 34, LDL was 148, today it stands at 73, and TG was 399, today it stands at 282. So all the lab works are within normal limits. So my question to you would be, which of the strategies listed below would be the best management strategy for our patient now? Is it desired non-HDL of less than 100 and then switch to Simvastatin at a dose of 80 milligrams at night? Or is it desired non-HDL below 100, then add Fenofibrate 160 milligrams daily? Or is it a goal of below 130, add niacin extended release at a dose of 500 milligrams at bedtime and titrate as tolerated by the patient with a target of 2000 milligrams? Or would it be a goal of below 130 and discontinue the Atorvastatin? I'll give you 10 seconds to choose the correct answer. So I would settle for answer C. This patient's primary dyslipidemia target was LDL with an initial desired goal of 50% or more reduction in the LDL from baseline using high intensity statin. Now, elevated TGs can cause a shift in the LDL-C particle size, which then impacts on the volume of space they occupy, thereby making the LDL concentration appear lower than it would be if the TG were back to normal and the LDL particles shifted back to their large size. The current calculated non-HDL is 139, warranting consideration for further therapy, in my opinion. Now, one option may be to increase the existing statin therapy to determine if higher doses any further lower the TG and raise HDL to a point where his non-HDL could be controlled. Now, additionally, one can add niacin, which could lower TG and raise HDL. Now, if tolerated, it may be an ideal choice for this particular patient we are discussing, and it maintains a low statin dose to minimize side effects. So it would be reasonable to add niacin to the current statin dose to avoid issues with the rhabdomyolysis and all those muscle issues that high dose statins cause. To improve tolerability of niacin, the use of the nighttime dosing for extended release formulation and premedication with aspirin 30 minutes prior to niacin administration would be in order. It would help you relieve the adverse effects. So I would consider adding niacin at bedtime and titrating gradually. Then of course, if the patient complains, I would give that premedication with aspirin half an hour prior to administration. So that's just a by the way. Let's move to the next question. It says JJM is a 46-year-old patient who was reported to the clinic with the following blood pressure history. In the previous visit, it was 154 systolic, 96 diastolic. Today, it stands at 149 systolic, 96 diastolic. So it's still above goal in my opinion. Basing on these results, which statement below is appropriate? Is it that the patient has pre-hypertension? Or is it that the patient's blood pressure is within normal limits? Or is it that the patient has hypertension? Or does this patient have stage 1 hypertension? I'll give you 10 seconds to choose the correct answer. In my opinion, he has hypertension and he's in stage 2 to be specific, and he should be considered for drug therapy with the goal of below 130 systolic and 80 diastolic. Let's move to the next question, which reads, Mr. EPM is a 75-year-old white male patient with refractory angina and he is currently receiving maximally tolerated traditional antianginal therapy of an ACE inhibitor, a beta blocker, a calcium channel blocker, and isosapide dinitrite. His vitals include systolic blood pressure of 112, diastolic 68, with a heart rate of 56, tending towards bradycardia. Despite this therapy, he is experiencing 2 to 3 angina episodes daily. He is no longer a candidate for PCI, according to your cardiac team, and he requests for further angina relief. So, you decide to initiate ranolazine. Now, which of the statements below most accurately describes the mechanism of action of ranolazine that you intend to include in his regimen? Does it inhibit the late sodium current in the myocytes, decreasing diastolic wall tension? Or does it decrease the catecholamine activity by blocking the adrenergic receptors on the heart? Or does it block the conversion of angiotensin 1 to angiotensin 2? Or does it reduce preload and dilate the large epicardiocoronary arteries? I'll give you 10 seconds to choose the right answer. In my opinion, A is the correct answer. Now, ranolazine is a novel antianginal medication that doesn't affect hemodynamics. It doesn't affect the blood pressure or the heart rate in order to produce a reduction in angina. It inhibits the late sodium currents in the myocytes, to be specific, and normally in ischemic myocytes. These late sodium channels cause an increase in intracellular sodium, which further results in an increase in intracellular calcium. Now, intracellular calcium overload directly increases diastolic wall tension and perpetuates this ischemia that our gentleman is complaining about. So by blocking these channels, you may have a net reduction in intracellular calcium, leading to a decrease in diastolic wall tension, and that would also, by extension, increase relaxation and would cause a decrease in angina. Now, beta blockers are the ones that decrease catecholamine activity, which is in option B. So that does not apply to ranolazine. And then the nitrates reduce preload. So that applies to the option D, not to ranolazine. Then the ACE inhibitors are the ones behind the conversion of angiotensin 1 to angiotensin 2. Ranolazine does not affect that process. It's not an enzyme inhibitor as such. It is the ACE inhibitors that block that conversion. That's just a by the way. So let's move to the next question. So Mr. SMK, a 54-year-old male patient, presents to your cardiac clinic with chest pain, and his latest EKG shows new changes, and troponins are detected. The troponin test is positive, and an NSTEMI is diagnosed by your cardiac team. So my question to you is, which of the following is a contraindication for the use of nitroglycerin in SMK's ongoing chest pain? You would like to relieve it. In which of these conditions would you not administer nitroglycerin? Would it be when the systolic blood pressure is 89 millimeters of mercury, or would it be if he has used Avanafil in the past 72 hours, or would it be if the pulse is 98, or would it be if he has a left-sided MI with a PE? I'll give you 10 seconds to choose the correct answer. So in my opinion, A is the correct answer. The use of nitroglycerin for acute treatment of acute coronary syndromes would be considered to be contraindicated in any patient with the following: if they have used a type 5 phosphodiesterase inhibitors within the last 24 hours and up to 48 hours, if that drug was tadalafil. And I would also be cautious if they had right-sided MI, not left-sided. Right-sided MI, that is preload dependent. And also if their systolic blood pressure was below 90, not below 89. And then if they had bradycardia or tachycardia. Now, Avanafil in option B has a very short half-life of 5 hours. And I wouldn't likely be lingering in this gentleman's body if it was administered 72 hours ago. So that makes alternative A our best bet. Which pair of antibiotics listed below are CYP2C inhibitors, which could decrease the metabolism of Coumadin or Warfarin and increase bleeding risks in patients with atrial fibrillation who are taking Warfarin? Would it be Bactrin or Septrin co-administered with Metronidazole, or would it be Metronidazole co-administered with Amoxicillin, or would it be Moxifloxacin co-administered with Linezolid, or would it be Ritonavir co-administered with Abacavir? I'll give you 10 seconds to choose the correct answer. So A it is, in my opinion. Now, metronidazole and sulfamethoxazole trimethoprim are the main antibiotics which are known to contribute the greatest to inhibition of the CYP2C9, which is the main route by which the S isomer of warfarin is metabolized. Now, any inhibition of CYP2C9 can significantly reduce the rate of metabolism and increase serum warfarin levels. And that would increase the potential for anticoagulation, raising risks of bleeding. Now, Ritonavir and Abacavir in option D are ARVs that are used in the treatment of HIV infection. They have nothing in common with the inhibition or activation of enzymes that metabolize warfarin. Moxifloxacin has no significant inhibition of the CYP2C9 enzyme, but it can interact with divalent and trivalent cations in the gut, so it would not be the correct answer either. Then linezolid interacts with substrates of the monoamine oxidase, not with CYP enzyme, so it would not affect our warfarin much. So I would settle for A. Let's move to the next question. If dopamine and dobutamine were administered to a patient with a low cardiac output who requires inotropic support, which of the side effects listed below would likely occur? Would it be reflex, symptomatic bradycardia? Would it bronchospasm in patients with hyperactive airway disease? Would it be tachydysrhythmias, including VTAC? Or would it be GI bleeding due to bowel hypoperfusion? I'll give you 10 seconds to choose the correct answer. So, in my opinion, the tachydysrhythmias, including VTAC, would be our best answer, since both these inotropes can stimulate the beta-1 receptors in the heart. Patients can experience an increase in heart rate, which can lead to tachydysrhythmias such as ventricular tachycardia and ventricular fibrillation, especially in patients with cardiac remodeling, as seen in the heart failure population. This greater risk of these tachydysrhythmias is the reason dopamine isn't one of the preferred vasopressors over norepinephrine, just as a by the way, in the management of septic shock. So let's move to the next question. Our last question. Which mechanism of action listed below best prescribes the effect of Idarucizumab, which is also known as Praxbind? Is it that it binds through non-covalent hydrogen bonding and charge-charge interaction? Or is it a humanized monoclonal antibody which binds to dabigatran and its acyl glucuronide metabolites? Or does it target and sequester factor 10A inhibitors such as edoxaban? Or does it restore thrombin generation by activation of prothrombinase? I'll give you 10 seconds to choose the correct answer. In my opinion, B is the correct answer. Idarucizumab is a specific reversal agent for dabigatran. It is a humanized monoclonal antibody that is administered IV, which binds to dabigatran and its metabolites with a greater affinity than the binding affinity of dabigatran to thrombin. And this neutralizes the anticoagulant effect of dabigatran because it opts to dissociate from the thrombin and to bind to idarucizumab. Now, the reversal effects start within minutes and hemostasis is restored within 11 hours when administered. So my highly esteemed and treasured viewers and listeners, that brings us to the end of this video. Now, if this video helped you in any way, I would like to remind you to give it a thumbs up and to like it. And if you haven't yet done so, I would like to urge you humbly to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. I sincerely thank you for listening and for viewing, and I hope to interact with you in part 26 of our pharmacotherapy MCQ series. Thank you for being there for me.